Right, so we'll go ahead and get started. Please, then we'll use the chat function and you can put your questions in the chat, or if you're here actually, you can also raise your hand. I'll try to manage that if you want to come on camera and ask your questions directly, or you can put them in the chat. Either way will work. We have a nice small group here, so feel free. And we've got some questions that also folks who, when they registered, they also asked. So we'll run through those as well. I see we have Professor Ortiz-Romero joining us. This is so exciting. So we're going to go ahead and get started. Let me introduce our esteemed panel of experts that we have joined us today, which is so exciting. We have Professor Pablo Ortiz-Romero, who's joining us from Madrid, Spain. He's professor of dermatology and the head of the Department of Dermatology at the Hospital Universitario. Okay, I won't say any of this right. Anyway, the University Hospital in Madrid. And we have Professor Evangelia Papadavid, who's the associate professor and chair of the second Department of Dermatology at the National and Capodistri. And oh, I won't say this. You guys are going to be not happy with me in my pronunciation, but she joins us from the University of Athens in Greece. And Professor Rudy Stadler, who's the head of dermatopathology at the University Clinic for Dermatology at Johannes Wesleyan Medical Center in Minden, Germany. So this is really exciting. We've got 3 expert cutaneous lymphoma clinicians to answer all of your questions. And as I said, we'll be you can put your questions in the chat, or if you want to use the raise hand function, I'll try to look and pay attention to the raised hand, and you can come on camera and ask your question directly of our esteemed, wonderful panel of experts here. So we're going to go ahead and get started. And again, welcome everyone. It looks like we've got folks from the Netherlands, the UK, from Sweden. I know we had Spain. So people from all over. This is also being recorded, so you can go back and watch it later if you miss anything, which is great. So we'll start with our first question here, and I will give our esteemed panel an opportunity to answer. Whoever feels drawn to answer the question, then we can just have a dialogue back and forth. So the first question is, when my skin gets extremely dry, what is the best regimen to use?
If I may, I recommend, usually I recommend petrolatum, Vaselina, what we call Vaseline. The best way to use petrolatum is after shower, with immediately after closing the faucet, with the skin wet. You apply a very thin layer of petrolatum, and this very thin layer attracts the water inside the skin, because during the shower, a lot of water goes inside the skin. If you don't do nothing, this water evaporates, and you get the skin even drier than before. But if you apply a very thin layer of something with oil, which is the petrolatum, the water is trapped in the skin and gets a lot of hydration of the skin inside. And it's very cheap, very convenient, very fast to use. And especially for males, we don't like oily sensation in the skin. So it's very, very convenient for everybody, but especially for men.
Good question, because men don't generally like to put things on their skin. It's not a typical habit. Professor Stadler or Professor Papadavid, anything to add? I know sometimes things are different in different countries with available products and so forth. So feel free to jump in.
Yeah, I actually agree with what Pablo said, that it's very important to keep the hydration of the skin after the shower. So it's very important to use something that traps the water in the skin. So this petrolatum or other kind of topical treatments that can trap the skin. The water in the skin are very important. However, if the skin is very inflamed, this sometimes can be a little bit of a problem in the patient because they might have more irritation, and but usually it works very, very well. In cases of fissured skin, we use like topical antibiotics also, or if there is inflammation, sometimes I try to use moisturizers, but it is a little bit tricky. Sometimes they might irritate the skin, so the patient has to find the balance with the moisturizers.
Professor Stadler, anything you'd like to add?
I think most patients have a skin barrier defect with CTCL. And so that is a key issue. And on the other hand, they don't try to wash themselves, take a shower every day. And there are some miscommunication ongoing. I always tell the patients to do daily a shower because all things has to go. But you don't take the washing lotions not on the skin. You don't have to clean that skin only in your intertriginous area. And then you can avoid what my dear colleague Pablo said, that you get the lipids out of the stratum corneum. And in addition to what they said, there are modern local treatments in addition with hydroxyurea. And hydroxyurea is binding water in the ointment. And you can do it with a low dose of hydroxyurea, 2.5 or 5%. So you have better water supply to the dry skin and protect the skin.
And is that a product commercially available,
it's
like at the pharmacy?
You just go into the web and you can look hydroxyurea repair creams, for example. So there are a number of products on the market which can be easily used.
Great. Great. Awesome. Thank you. Thank you. Okay, so we have a question here from James, and he's had treatment success with Ladaga chlorethamine, and it sounds like more success with the topical treatment than the UVA or UVB. And he's wondering if the Ladaga methchlorothamine can be used as a long-term treatment, knowing that it is, pretty potent. So there.
Well, yes, I can respond if you want.
Great, please.
So there is no time limitation for the use of clomiphene gel or Ladaga. So no, so it's not resorbed systemically, so it's acting locally, and it's inducing caspasis. So that means lymphocytes die and are turned into necroptosis. So that's the principal mode of action of this compound. And so longer you using it as a patient, don't give up. Even colleagues of us showed that even after 1 year or so on, they still get better under the treatment of clomiphene gel.
Right.
There was for a long time we were worried about the possibility of the drug could be absorbed and have systemic adverse events, but it seems that the amount absorbed is almost undetectable and no adverse events. So no systemic adverse events.
Mm-hmm. So good to use for a long term. I mean, it's been available now. I know in the US it was approved back in, I want to say 2014 2014, maybe something like that. I know Ledaga was a little bit later in Europe. I don't know if it's available in every country. That's part of the challenge, but is it available in Greece?
Yeah, well, Ledaga was approved in EU in 2018, and it was available and it's still available in some countries, as in Greece, on a patient basis. So we have to, as physicians, we have to file a query at the national system for each patient. We think that it's a suitable patient for Ledaga. And we have so far also a very good experience for the last 6 years using this topical treatment. And I think it's one of the best treatments we have as a topical treatment, because as Rudy also said, and Pablo, the efficacy even increases with time. And in very rare cases, there is a kind of dermatitis, which can be very intense in very, very few patients. But most of the time it's very well handled. And if we have patients now, they use it for 6 years. So, and they're very happy using it.
That's great. That's great. And just as kind of a follow-up question, can you use that in conjunction with other therapies as well? I know we do a lot of combinations sometimes, so.
Yeah, we use it with most of the time combined with interferon, and sometimes with PUVA or UVB, and other treatments. We can be used either with topical or systemic treatments.
Great.
Especially with topical corticosteroids, we use a lot with topical corticosteroids because topical corticosteroids can improve mycosis fungoides, and on the other hand, they are very useful to reduce the irritation that produces the Ledaga. So very frequent to combine with corticosteroids.
Okay, great. And it sounds like James has had some good experience with it. So it's always nice to have good therapies in our toolbox, and hopefully we'll continue to add more as time goes on.
I think
go ahead.
Susan, that is a very important topic, because the combination is very important, especially patients who have stage 1B, more than 10% involvement of body surface. And to keep them in this stage, and you know, this stage means that the survival rate lies between 20 to 30 years. So life expectancy is almost in normal range compared to the population who is not involved or suffering of cutaneous T-cell lymphoma. So as what Leah and Pablo said, so the combination with non-toxic drugs or also with a small band UVB is possible. It is not a problem. It's of additional complexity, additional effect for the patients.
Right, so it can be used long-term and it keeps everybody stable, right? I think that's one of the other challenges with folks that are newly diagnosed, particularly, is, you know, you get a cancer diagnosis and you want to eradicate the disease, but in this case, we want to manage, right, to keep everybody to have best quality of life, use the least toxic treatments available, you know, just more chronic than getting rid of it with big toxic drugs.
Well, if I may add to what Rudy has said, patients feel that with Ledaga, they have a more long-term maintenance, better maintenance of the disease compared to use of, let's say, potent steroids. So I think it's a very good topical treatment for these patients that Rudy described with 1B disease, that we can achieve, in some of them, we can clear their skin, but some of them have a partial response. So if we add on a topical treatment such as Ledaga, then I think we can maintain their skin almost clear for long term compared to what we used so far, like potent topical steroids in the past.
Great. Yeah. Awesome. Thank you. Okay. We're kind of on a theme here. Question: will narrowband UVB therapy stop or slow down the progression of my early patch stage MF? And what are the treatment goals for this therapy? Good question. Anyone?
I think that the treatment goal of any therapy of mycosis, I explain to my patients very frequently, we cannot cure mycosis fungoides usually. So our plan is not to cure you, but to keep you as less lesions as possible and as good quality of life as possible. And I would like, I think that maybe you can die in 40 years time or 50 years time because of a drone of Amazon falls into your head, maybe with patches on your skin, but not because of your patches of your skin. So in this case, patients relax and are aware that something that Rudy mentioned, that is very frequently the history of the disease is very prolonged, 20 or 30 or more years. So,
Right.
So most patients mix the term cure to free of disease.
Mm.
And what is our goal of all physicians who are dealing with cutaneous T-cell lymphoma and also other diseases, to keep the patient free of disease. Cure is a very high term you can have as a child if you have chills, but in the elderly you get zoster again when the immune system doesn't remember the virus. So this we have to discern and to explain the patient. We will keep you long-term free of disease. That does not mean you are cured.
Mm. That's a very good, I like that terminology, free of disease, because I think to your point, you know, especially when you're newly diagnosed, it's like, just get this out of my body. I know that was my thought when I was first diagnosed, like, let's get rid of it. It's done. And here I am 30 some odd years later, right? Still managing. So free of disease, just living life and moving forward. And as we get newer treatments, hopefully we'll be able to manage people that may have more challenging disease than the early stage topicals.
Yes. And if I may add also, it's that patch stage disease, I mean, we have a big discussion now worldwide about this patch stage and plaque stage. Patch stage disease, I think universally is considered as a very mild disease, and especially when it's less than 10%, but even in patients more than 10%. So I think that we don't really see these patients as patients that have a poor life expectancy or anything like that. It's like, in my perspective, is like having a patient with a chronic disease like psoriasis, and then keep a follow-up in these patients, but explain to them that this is not something that they should worry about their long-term expectancy.
Great. Okay, so let's see. Next question. I'm suffering with mycosis fungoides, age 32. 2 years ago, she got married and wishing for a child. She'd like to know, can the disease affect her ability to have a child? And I guess the secondary, I'm going to add on to this, could it be passed on to her child? So that's a good question. Fertility and heredity.
No, it can't be passed over, and she can have more childs for their personal family planning. The only thing we have to keep in mind, we have non-toxic systemic therapies like retinoids, And so that of either RXR retinoids, the bexarotene, or the RRR retinoids, the neotigazole, they are all teratogenic. And teratogenic means that during pregnancy, as earlier as you take this drug, the more prominent are the fetal damage. So this has to be kept in mind. And if you take this drug, you have to have birth control up to 2 years after stopping the drug. So this is very important for the patients. And in addition, we had in the United States the 13-cis retinoic acid, this isotretinoin. And isotretinoin is the drug, still the drug for acne therapy. So it's most popular, most effective drug. And so also these patients have to be aware that these compounds are teratogenic. And as you know, acne is more in younger people, but can also affect females in the second, third decade of life. So this is very, very important, and is a very obligation also for us as physicians to explain that to the female patients.
So good to have those kinds of questions, right? If you are of childbearing age and have an interest in having children, talk about what therapies, depending upon the individual's disease presentation and so forth, and what the ramifications are, because we have options, right?
Yeah. So I think what Rudy said is very important, and it's fortunate that the disease is more often occurs in elderly patients. So we have still young patients and female patients that have mucosis fungoides or Sézary. And I think that usually they don't have, I mean, the patients we have, they don't have a lot of problem during their pregnancy. However, if they discontinue some treatments like bexarotene or neotigazole or whatever, acitretin, they might be a flare after pregnancy sometimes. And usually during the pregnancy, they can use topical steroids, and they can have a narrowband UVB. So that's I think quite a treatment that we can do in cases that their mucosis fungoides flares. So
something important to mention is that not only females should be careful with treatments. We have treatment, for example, methotrexate, in which there is a recommended delay in males between the last dose of methotrexate and the moment to start looking for a kid.
Good to know. Yeah, and I think, you know, as we've, at least with the Cutaneous Lymphoma Foundation, there have been more folks that are younger being diagnosed, and hopefully that's a good thing, right? That we're getting people diagnosed sooner and they're not being misdiagnosed for years and becoming more aware. So I think it's an important thing to make sure that folks that are of childbearing age have those kinds of conversations, and we're collecting data and all of that good stuff. So our next question, this is also quite interesting and a little bit along the lines of, you know, that cure word. Is there any hope in finding a cure with the next type of therapies like CAR T, or maybe others that we don't even know about? So maybe we can talk a little bit about these new approaches to therapeutics that are, you know, everybody's talking about it, not necessarily in cutaneous lymphomas, but does anybody want to take CAR T and new technologies, I guess is what we're now calling them? Yeah.
CAR T cells are especially, CAR T treatments are especially difficult treatments because we are trying to kill T cells. So they are very, very useful, and we are using, not we, especially hematologists, are using a lot against B cell lymphoma. but against T-cell lymphomas, they are very, very difficult because they are still very similar, and the malignant cells is not rare that is able to kill the T-cell that we are trying to use as a treatment. So it's very, very difficult. Probably there are several approaches, and I think that we will see in the next meeting in Lausanne some approaches to use different cells against malignancies. But for the moment, it's not very easy. We are very, very early. The development for the moment is very scarce.
Right. Do we want to talk about any things currently in clinical trial that might be promising? Anybody have any thoughts on some new things coming down the pike, maybe outside of CAR-T?
Besides the cellular treatments like CAR-T cells, which is very open, as Pablo said, the T-cell are the malignant guys, and and then you are not able to dissect between the benign and the malignant. So, and there are some drawbacks also with CAR-T therapies. Patients died of it or get secondary cancer. So that is still an open question and far away to be introduced in cutaneous lymphoma. But, you know, there are new approaches from the molecular point of view that most signaling are moving in the STAT pathway. And so there are compounds like YAC and STAT medications, which are used for benign diseases like atopic dermatitis and some others which were never being addressed with efficient medications. And there are also a study by Patrick Brunner in New York to use YAC inhibitors at the pivotal study. And so we thought from the theoretical point of view that might be promising, but we were also disappointed using, for at least the antibodies. Let's say dupilumab, it's a TH2 inhibitor perfectly, but it was deteriorating early cutaneous T-cell lymphoma or demasking atopic dermatitis as CTCL because these patients progressed under this treatment, and we made a caveat not to use dupilumab in these patients. So we couldn't foresee that. All data, experimental data, pointed that it would be functioning. And then Susan Querfeld, she published high-ranked about ZIRP alpha, that is a don't eat molecule. Also, this was a very hope in introducing it into CTCL, and so it didn't work at all. And Dr. Kodadaust at the World Lymphoma meeting, he talked about all these new combinations or new molecules, and it was rather disappointing in a certain way. So we still have to understand more what kind of molecules can we really address. In the moment, in the next, let's say, 5 years, look forward what my dear colleagues said, I don't see any major change in what we now can apply to our patients.
Rudy, I am more optimistic than you. We have a couple of drugs that I think that will reach the market. I don't know if in 5 years, but maybe. One is lacutamab. It's a monoclonal antibody that the studies for the moment looks very good, and I think that it's a monoclonal antibody against KIR3DL2. It's a protein that has on the surface of the cells. And the other you are involved in that is resminostat. You should mention.
Yes, but we are talking, I understand it differently. Let's see,
okay.
As Susan thought, that we will have a drug which is really curing
No, not curing.
the disease. So that I would question that we will be in the position to have that in due time. But I agree with Pablo. We have lacutamab is coming up, but lacutamab is, to my opinion, very efficient for leukemic CTCL.
Agreed.
And
Yeah.
it will be at least as potent and what we nowadays have as mogamulizumab. And so that will be, I think, a step further in the development. But if this one antibody will be as efficient in solid cutaneous T-cell lymphoma, like tumor stage, I personally rather doubt that this would be a game-changing. Then we did the largest maintenance study with HDAC inhibition, modification, gene modification. So we could show that this was efficient maintenance therapy for cutaneous T-cell lymphoma patients. So that we will have maybe hopefully next year approved by the EMEA, that's the European Commission, to have another compound for the treatment in CTCL.
Yeah. I would like to add to this that the main problem with the new drugs is that we don't really have very good biomarkers. We don't really have specific genomic events that we know that targeting them, we will have a cure for the disease. And there are some cases in the literature that if there are some mutations or structural variants, I mean, there is a very good response. But at the moment, I think we need more biomarkers and more into genomics to achieve a better response with the current drugs. That they may work in a specific target of our patients, group of our patients. And what also is important to say is that there are not very many clinical trials because it's a rare disease, and there are few phase 2 trials that exist at the moment in cutaneous lymphoma. And probably if we have more advances in the genomics, then we can have more trials, because it has to be translational correlation there to have better results.
Right. Thank you. Okay, one more question around phototherapy. After reaching 300 sessions of phototherapy, what would be the best approach if the patient still needs treatment at stage 1A? So I guess, what's the approach on phototherapy in early stage disease? Do you take a break? Do you continue? Do you have maintenance? Like what is that over that long-term treatment period, like years and decades? Any thoughts on that?
Yes, I can answer or try to answer. Nowadays we don't have any more PUVA worldwide because methoxyproline is not anymore available. So we are concentrating of narrowband UVB. And one of the most principal, what I always told physician colleagues who doing phototherapy is not to increase the dosage. Because what we know from our experimental work from the past, let's say it's always 30, 40 years back, it's that the antigen presentation from the Langerhans and dendritic cells in the epidermis towards the lymphocytes is only depending on a few millijoule of energy to block this. So you don't have to increase constantly the dosage. And by increasing the dosage over time, over years, you increase the risk of secondary cancer. And that is a concern, what patients and we are as physicians and responsible for the patients have. So if you do it low dose, narrow band UVB, you can go a long time for the patients. And then you have to think intelligently. During the key summer months, these patients can use with sunscreens the outdoor situation, if it is, and then start in autumn back to use once a week or 2 times a week, depending on the response, this UVB treatment over the winter time and until spring, and then stop and so on. And so you can continue over years with this very important UVB therapy for the patients.
I would like to comment. You mentioned the one patient asking about the stage 1A. The stage 1A means less than 10% of body surface with the patches and plaques. And there is one possibility, is not treatment at all. So it's not mandatory to treat the patient with stage 1A. This does not mean to discard the patient and to say you don't need to come back any longer, but you have to have control of the patient, see the patient regularly, explain very good the alarm problems if the lesion expands, the lesion expanding to more than 10% of body surface area involved, or tumors or lymph nodes or whatever. But it's not mandatory to treat the patient with less than 10%. You have to explain the patient. Some patients say, I don't want to see any patch on my skin, and you treat. But there is no real need. We all agree about that. I think that we all agree about that.
Great.
Yeah.
Oh.
But we also do the same. We just treat during if the patient are suitable for phototherapy, we treat it during the winter, and then we advise to go to the sun in the summer. And I agree with Rudy. If we use low dose, we don't have to exceed millijoules or several millijoules to get a result, because we can get a result with low dose of narrowband UVB. And sometimes if the patient is willing to come to the hospital, then we reduce the frequency of the treatments, but other times we just continue with topicals. So yeah, this is the regime of treating.
Professor
Yes.
Stadler?
I have one point. We have in our guidelines, in the US guidelines, European wait and see policy. It's also mentioned for stage 1A. However, due to what we saw in molecular investigations is that even in patients with stage 1A, there can be very dramatic molecular changes already. So if you think about fire in the US, so you have to distinguish even a small fire in California to prevent the spread over the northern part of California. So what I mean with this is just extinguish the fire. The fire means the initial CTCL that the clones are not able to expand. That's one notion. And of course, you have to balance. If you harm more the patients, and you help the patients with the disease. But in my experience over all these decades, it's better to extinguish every lesion you see, that patients feel free of any signs of CTCL. So they are free of disease.
Right. Okay, we have a couple minutes left. I'm going to try to get to this last question, and hopefully this is an easy one. Patient had MF, diagnosed in 1996, and was verified by biopsy. In 2021, they were diagnosed with lymphedema in their right leg. and they had knee surgery, is there any connection between the lymphedema and cutaneous lymphoma?
In case of,
No, I don't think so.
there is nothing, yeah.
No.
Yeah. See, I thought that was an easy question because we are right on time. That would be an easy no question, which doesn't usually happen in this disease, right? We have so much back and forth. Oh, now we have another question. All right, so we have a minute. When you say low dose UVB, what does that actually mean in numbers, actual millijoules? So what would you consider low dose UVB?
0.5 millijoule.
0.5.
Mm.
Okay, great.
Not exceed
And
one, not exceed to over 1 millijoule. So it can be 0.5 to 1, but not exceeding this upper
Okay.
limit.
Great. Excellent. Excellent. Look at that. Right on the money. Wonderful. Thank you. Thank you, everyone, for your questions. Thank you to our esteemed panel. It's really wonderful to have all of you with us, and I'm just grateful that you took the time on your Saturday to join us and answer questions. And it's really good to see you all. And I'll let you all get back to your Saturday and not working, I hope. And now we'll have a 30-minute break, and our conference will resume at 12:30 Central European time. We'll do our peer-to-peer networks where all of us patients get to have a chat. And so you'll close your Zoom window. I have to read the instructions now. So please close your Zoom windows and return to the meeting platform in your web browser. And if you've closed your web browser, there's some information in the chat with the link to get back into the main broadcast. So we'll see everybody back in 30 minutes for our networking peer-to-peer. And thank you so much to our esteemed panel of experts. Look forward to seeing you in a couple weeks. So thank you all again.
Thank you very much, Susan.
Thanks everyone for your great questions, and we'll see all of our participants in a half an hour. So have a great rest of your Saturday. Thanks everyone.
Thank you, and all the best to you all. We see you in Lausanne. So.
Yes. Great.
See you all, yes.
Thank you.
Bye-bye.
Bye-bye.